Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, including physicians, trainees, nurses, pharmacists, and respiratory therapists. Each episode is designed for busy clinicians who want to understand not only the headline result, but also the clinical question, study design, key findings, limitations, and bedside relevance. The goal is to make new evidence easier to digest and more useful for real-world practice. Whether you are on service preparing for rounds, teaching learners, or simply trying to stay current. I originally started making these episodes to support my own learning and review. I am sharing them publicly in case they are helpful to other clinicians and learners who are trying to keep up with the growing critical care and pulmonary literature. Everything you hear is for educational purposes only and should not be taken as medical advice. Clinical decisions should always be made in the context of the individual patient, local practice standards, and the judgment of the treating clinical team.
Today we're talking about sodium bicarbonate for metabolic acidosis in shock. The patient is on vasopressors, the pH is low, and someone asks, should we start bicarb? The SODa-BIC trial gives us a clear, blinded answer.
It really does.
Welcome to this deep dive for PRISM Rounds, Season 1, Episode 47. I'm genuinely thrilled you could join us for this one because we are unpacking a clinical scenario that, well, every single ICU and acute care clinician just knows in their bones.
Oh, absolutely. It's universally relatable.
Right. I mean, you listening, you have lived this exact moment. You're at the bedside. It's 2 a.m. The unit is quiet except for, the rhythmic hum of the ventilators. And then a monitor starts alarming.
The dreaded 2 a.m. alarm.
Exactly. The patient in bed 4 is hypotensive. The arterial blood gas just printed out. And as we all know, absolutely nothing good ever prints out at 2 a.m.
No, it is never a pristine textbook printout at that hour. It's a piece of paper that immediately accelerates your own heart rate. So our mission today, for you listening, is to rigorously examine the New England Journal of Medicine's SODa-BIC trial. We want to determine if correcting a moderate metabolic acidosis in vasopressor-dependent shock actually improves patient-centered outcomes. Or, and this is the big question, if it just makes the numbers on the screen look better.
Just treating the monitor.
Right. We are going to dissect the data, the physiology, and really the psychology of the ICU to see if we are treating the patient or merely treating the chemistry panel.
And that right there, that's the core tension for you at the bedside.
Yeah.
You're looking at that slip of paper. The lactate is high. The base excess is just profoundly negative. The pH is sitting right at, say, 7.26. The bedside nurse is hanging the second bag of Norepi. You're watching the mean arterial pressure struggle to stay above 60. And, well, someone in the room inevitably says it.
They always do.
The reflex, the classic question that echoes through intensive care units worldwide. Do you want me to hang some bicarb?
It's an incredibly powerful reflex. I mean, as clinicians, we are trained from our earliest days in medical school to just normalize abnormal numbers.
Does a low number make you go up?
Exactly. A potassium is low, you replace it. A blood sugar is high, you give insulin. A pH is low, you want to give base. It's ingrained in us.
It totally is.
But before we get to the solution that the SODa-BIC trial tested, we really need to fundamentally understand the problem. We need to unpack why this specific physiological derangement, acidemia, is so universally feared in the ICU.
I completely agree. We can't really talk about the cure without dissecting the disease first. Let's talk about the burden of acidosis.
Let's do it.
Because why do we care so much when that pH drops in a patient who is actively in shock? I mean, on the surface, it's just a high concentration of hydrogen ions in the blood plasma.
Just some protons.
Right. Why is a tiny little proton so terrifying to a critical care team?
Well, we care because acidemia is fundamentally hostile to human physiology. It is not a passive bystander. It is an active saboteur, particularly when it comes to the cardiovascular system.
Okay, break that down for us.
Sure. When you look at the evidence, severe metabolic acidosis is ubiquitous in critically ill patients, especially those with sepsis, renal failure, or hypervolemic shock. And it brings this whole cascade of devastating associations. But we really need to look at the how and the why behind the damage.
Right.
Let's start with the heart itself.
Because acidemia actively impairs myocardial contractility. But let's really visualize that for the listener.
Yeah, let's zoom in.
You have a patient whose heart is already struggling to maintain cardiac output, right? They might be septic, their systemic vascular resistance is plummeting, and the heart is trying to compensate by beating harder and faster. How does the acidic environment functionally weaken that cardiac muscle at a cellular level?
It all comes down to calcium handling within the myocytes. To understand this, we really have to visualize the inside of a heart muscle cell.
Okay, I'm picturing it.
So, for a heart muscle to contract, an electrical signal travels down the cell membrane and triggers the release of calcium from an intracellular storage vault, the sarcoplasmic reticulum.
The SR, right.
Right. That calcium then floods the cell and binds to a specific protein called troponin C. When calcium binds to troponin C, it physically moves a blocking protein out of the way.
Like unlocking a door.
Exactly like that. It allows the muscle fibers, the actin and myosin, to grab onto each other and pull, which creates a contraction.
So calcium is the key that unlocks the cellular engine of the heartbeat. Where do the hydrogen ions from the acidemia come in? What are they doing?
Hydrogen ions act like a competitor trying to jam that keyhole.
Oh, wow.
Yeah. In an acidemic environment, you have this excess of hydrogen ions flooding the intracellular space. These protons actively compete with calcium for those exact same binding sites on troponin C.
So they just get in the way.
They get completely in the way. So even if the cell releases enough calcium, the calcium cannot bind effectively because the hydrogen ions are blocking it.
That makes so much sense.
And it gets worse. Furthermore, the low pH impairs the sarcoplasmic reticulum from releasing the calcium in the first place, and it also impairs its ability to pump the calcium back in to allow the heart muscle to relax.
That is a phenomenal breakdown. So the heart becomes structurally weaker. It literally can't squeeze as hard because the actin myosin can't interact properly, and then it can't even relax properly either.
Exactly.
You essentially induce a transient cardiomyopathy purely through chemical interference.
That's a perfect way to put it.
But the heart is only half of the cardiovascular equation, right?
Right.
The other half is the vascular system, the pipes.
Precisely. And this is where acidemia does its most famous damage in the ICU. Acidemia induces vascular hyporesponsiveness.
The dreaded catecholamine resistance.
Yes. It reduces catecholamine responsiveness. This means that the endogenous adrenaline and noradrenaline your patient's own adrenal glands are producing, plus the exogenous norepi you're pumping into their veins via the central line, they simply do not work as well.
Okay, let's unpack this for the clinician listening, because this is the exact reason why the reflex to hang bicarb is so deeply ingrained in our psychology.
It really is.
You have a patient on escalating doses of norepi. You're going up from 0.1 to 0.2 to 0.3 micrograms per kilogram per minute. Their blood pressure is still soft. You know the acid is making that norepi less effective. Naturally, you think, if I give base, I neutralize the acid, the norepi binds better, the blood pressure improves, and I save the patient. But mechanistically, why does the acid block the norepi?
It is all about receptor conformation. The receptors on the smooth muscle cells lining the blood vessels, specifically the alpha-1 adrenergic receptors, they are complex, three-dimensional protein structures embedded in the cell membrane.
Right.
Norepinephrine acts like a highly specific key designed to fit perfectly into the lock of that alpha-1 receptor. When it fits, it triggers a cascade inside the smooth muscle cell that causes the blood vessel to constrict, which raises the blood pressure.
And proteins, they change their shape based on their environment, right?
Exactly. The three-dimensional shape of these receptor proteins is highly dependent on the local pH. When the environment becomes highly acidic, the excess hydrogen ions alter the electrical charge distribution across the protein.
So it warps it.
It literally changes its physical shape. It warps the lock. So now, even though you are flooding the bloodstream with norepi, the key no longer fits the lock perfectly.
Wow.
The signal to constrict is blunted. You get vasoplegia, a profound loss of vascular tone.
It makes perfect physiological sense on a whiteboard. You fix the pH, the receptor goes back to its normal shape, the norepi binds, the vessels clamp down, and the blood pressure comes up.
It's very elegant in theory.
And the stakes couldn't be higher because beyond the cardiovascular collapse, this state of acidemic shock is highly associated with acute kidney injury, the need for renal replacement therapy, and ultimately mortality.
It does make sense on a whiteboard, as you said. The logic is incredibly seductive. But that brings us to the core dilemma we face as critical care physicians.
The big debate.
A dilemma we have been arguing about in the literature and in the break rooms for decades. Does the early aggressive correction of acidemia with an exogenous buffer actually influence renal outcomes and organ support requirements? Or, and this is the kicker, is the acidemia merely a bystander?
A bystander.
Right. Is it just a biochemical marker of how severely ill the patient is rather than the primary driver of their deterioration?
Wait, I want to pause there and just challenge that concept of the bystander for a second. Are you suggesting that the acid might not be the thing killing the patient, but rather just, I don't know, the smoke coming from the fire?
That is exactly the debate. Think of a house on fire. The smoke is billowing out of the windows. The smoke is toxic, yes, but if you just set up giant fans to blow the smoke away, you haven't put out the fire.
The house is still burning down.
Exactly. The profound shock, the lack of tissue perfusion, the mitochondrial dysfunction that is the fire, the lactic acid and the metabolic acidosis are just the smoke. For years, we wondered if giving bicarbonate was just blowing the smoke away while the patient's cells continued to burn.
And we haven't been debating this in a vacuum. We have had data. We have had major trials try to answer this.
We have.
So to truly appreciate the SODa-BIC trial, we have to talk about the context leading up to it. We need to look at the flaws in the prior data. Let's rewind the clock a bit and talk about the BICAR-ICU trial from 2018 and the subsequent analyses.
Yes, those trials are absolutely essential context. The BICAR-ICU trial was a landmark study in France. They looked at patients with severe acidemia, and I really want to emphasize severe. They find it as a pH of 7.20 or less.
That's pretty low.
Very low. They randomized these patients to receive either 4.2% sodium bicarbonate or no bicarbonate. And what they found was fascinating, but highly complicated.
Complicated how? What were the headline results?
Well, in the overall population of the original BICAR-ICU trial, giving sodium bicarbonate did not lead to a statistically significant lower 28-day mortality. The primary endpoint was essentially negative for the whole group.
Okay, so a negative trial overall.
Right. However, they looked at several secondary endpoints, and this is where things got really interesting. The BICAR group did show a lower use of renal replacement therapy.
Oh, okay.
And furthermore, in a pre-specified subgroup of patients who already had acute kidney injury, specifically AKI network scores of 2 or 3, there actually seemed to be a significant mortality benefit and a pronounced reduction in the need for dialysis.
Okay, so that trial comes out, and suddenly every critical care doctor is saying, aha, we knew it. BICAR protects the kidneys, especially if they're already injured.
Yep, it validated everyone's inherent bias to fix the numbers.
But here's where I have to push back on how those trials changed practice and why the critical care community desperately needed the SODa-BIC trial. Those prior trials, including BICAR-ICU, they were open label, unblinded.
Yes, they were.
The doctor at the bedside knew exactly who's getting the bicarb and who is getting the control.
Which introduces a massive, almost insurmountable potential for bias, especially when the outcome you are measuring is the initiation of a therapy like dialysis.
Exactly. Let's put the listener in the shoes of that clinician. We need to talk about the intense psychology of the bedside clinician in an open-label trial.
It's a huge factor.
You're taking care of a 30-year-old patient with severe sepsis. They are randomized to the control group. You are strictly forbidden from giving them bicarb.
Okay.
You check their morning labs. Their pH is 7.18. Their potassium is 5.2 and creeping up. Their urine output has been minimal for the last 8 hours. You are watching them intensely.
And you're getting nervous.
Very nervous. You know you can't give bicarb to temporize the numbers, to drive that potassium into the cells, or to make the pH look safer.
Yeah.
So what is your threshold to pull the trigger, call nephrology, and put in a vas cath for dialysis?
Oh, your threshold is naturally going to be much, much lower. You feel your hands are tied therapeutically. You're watching a slow-motion car crash on the blood gas monitor.
Right.
Because you are denied the intermediate step of a buffer infusion. Your anxiety peaks, and you move to the definitive intervention renal replacement therapy much sooner than you otherwise might.
Right. Now, conversely, imagine you were caring for that exact same patient, but they were randomized to the bicarb group. You hang the bicarb infusion, an hour later you check the gas. The pH is now 7.25.
Better.
The potassium drops a little bit to 4.8 because the acid correction shifted it intracellularly. The patient's actual urine output hasn't improved. Their shock hasn't resolved. They aren't really clinically better, but the numbers on the screen look significantly safer. Your anxiety drops. So you wait. You defer the dialysis line. You tell the team, let's give the kidneys another 12 hours to wake up.
This is an inherent, profound bedside bias. The unblinded nature of those trials means we could never be truly sure if the bicarbonate actually possessed biological properties that protected the renal tubules from ischemic injury.
Or if it just made the doctor feel better.
Exactly. Or if it simply functioned as a psychological anxiolytic for the doctors, giving them the comfort to delay initiating renal replacement therapy.
It treated the doctor, not the patient. That is a brilliant way to put it.
Yeah.
And that is exactly why we desperately needed a blinded trial to resolve this. We needed a scenario where the clinician looking at the patient and making the decision to dialyze had no idea whether the patient received a buffer or a placebo.
And that is exactly the structural and methodological flaw that the SODa-BIC investigators set out to eliminate. They designed a trial specifically to remove that bedside bias.
Okay, let's transition to how they actually built this study.
The mechanics of this trial are a masterclass in critical care research. This was a pragmatic, adaptive, double-blind, randomized clinical trial conducted across 55 intensive care units in 7 different countries.
Wow, 55 ICUs across 7 countries. That is a massive logistical undertaking, but it gives us incredible external validity.
It really does.
When a trial is done in one single academic center, you always wonder, will this work in my community hospital? But across 55 centers globally, you capture a vast array of practice patterns. So who exactly were they enrolling? What were the inclusion criteria?
They enrolled adult patients with metabolic acidosis, but unlike the previous BICAR ICU trials that looked exclusively at severe acidemia, a pH of 7.20 or less, SODa-BIC looked at a broader, incredibly common ICU population.
A moderate folks.
Yes, they targeted moderate acidosis. The pH inclusion criteria was anything below 7.30. They also required a base excess of -4 millimoles per liter or less, ensuring there was a true metabolic component.
And they had to control for respiratory issues, right? Because a patient with a pH of 7.28 could just be hypoventilating.
Exactly. To ensure they were isolating metabolic acidosis, they controlled for respiratory acidosis by requiring a partial pressure of arterial carbon dioxide of 45 millimeters of mercury or less in unintubated patients, or 50 millimeters of mercury or less if the patient was intubated.
So we have a moderate to severe metabolic acidosis. But the real kicker for the inclusion criteria, the thing that makes it so highly relevant to our listeners on their next shift, is that these patients had to be receiving a continuous infusion of a vasopressor.
Yes, that's crucial.
These are not just patients with a low pH from diabetic ketoacidosis who are hemodynamically stable. These are patients in shock.
Yes. The investigators isolated a highly specific, high-risk subgroup prone to acute kidney injury and cardiovascular collapse. Patients with hypotension requiring vasopressors who also have concomitant metabolic acidosis.
Got it.
Once enrolled, the intervention itself was a highly structured, dynamic 5-hour protocol. Patients were randomized to receive either sodium bicarbonate or a true placebo. And as I mentioned, it was dynamic. They didn't just hang a fixed dose and walk away.
I really appreciate that dynamic design because it mimics how we try to practice at the bedside. We titrate to effect. So how did the protocol actually work?
You start the blinded study infusion at an initial rate of 100 milliliters per hour. Then, the protocol mandates checking arterial or venous blood gases at precisely 1 hour and 3 hours after initiation.
Okay, tight monitoring.
Very tight. Based on those blood gases, the clinical team, who were completely blinded to what fluid was actually hanging in the bag, adjusted the rate according to a strict algorithm.
How so?
If the pH was still below 7.30, they kept the infusion humming along at 100 milliliters per hour. If the pH climbed to a safer zone between 7.3 and 7.35, they dropped the rate down to 25 milliliters per hour.
Makes sense. Back it off a bit.
And if the pH rose above 7.35 with a positive base excess, meaning the acidosis was essentially corrected, they stopped the infusion entirely.
It was a tight, controlled 5-hour window. After 5 hours, the steady infusion was stopped entirely and not restarted. Now, this brings up a fascinating methodological detail and one that I really want to grill you on.
Oh, I'm ready.
How exactly do you blind sodium bicarbonate?
It is a significant challenge. Sodium bicarbonate comes in distinct concentrations and has a very specific osmolarity.
Right. And here is where I have to challenge the trial design, because this is something that comes up in journal clubs all the time. To blind the trial, the active comparator was sodium bicarbonate diluted in 5% dextrose, making a final concentration of 600 millimoles per liter.
Correct.
The placebo they used to match it was simply 5% dextrose alone. D5W. Are we not comparing apples to oranges here?
I hear you.
I mean, one fluid is a highly concentrated sodium-rich alkaline buffer. The other is essentially hypotonic sugar water.
Yeah.
If you give a patient in severe distributive shock hypotonic fluid, that fluid does not stay in the blood vessels. It leaves the intravascular space rapidly and diffuses into the interstitial and intracellular spaces.
That's true.
Aren't we introducing a massive physiological confounder by using D5W as the placebo for a patient on vasopressors?
That is a very astute, highly technical critique. And honestly, it is a point the authors explicitly address in the trial limitations. You were absolutely right regarding the fluid dynamics.
Right, because it feels like a big deal.
It does. 5% dextrose is hypotonic and physiologically distinct from the hypertonic sodium-containing carrier of the bicarbonate solution. However, we have to look at the reality of trial design. This was literally the only feasible way to maintain perfect blinding across 55 centers.
Why couldn't they use normal saline?
Because the solutions had to be visually indistinguishable, and they couldn't use normal saline as the placebo because mixing bicarbonate in saline creates a massive sodium load. That would be easily identifiable by routine lab draws and would cause extreme hypernatremia, which unblinds the clinician immediately.
Right, they'd see the sodium hit 155 and know exactly what bag was hanging.
Exactly. They even ran technical reports and mock trials prior to the actual study proving that bedside clinicians could not tell the difference between the bags.
The ultimate blind taste test, just for IV fluids in the ICU.
Exactly. But to directly answer your concern about the physiological impact of giving D5W to a shock patient, we really have to look at the volume and the timeline.
Okay, let's look at it.
This was a brief, strictly limited 5-hour infusion window. The median volume infused in both groups was only 500 milliliters.
Oh, that's not much at all.
It's really not. Half a liter over 5 hours is 100 milliliters an hour. Over that short time frame, and with that relatively small volume, the investigators reasonably concluded that the hypertonicity of the placebo was highly unlikely to meaningfully skew the primary clinical outcomes of death or dialysis at 30 days.
Yeah, 500 milliliters of D5W isn't going to make or break a patient on norepi.
Right. The statistical preservation of the double-blind was vastly more important than the minor fluid dynamic differences of that volume.
I can accept that. The rigorous elimination of the clinician's psychological bias, the blinding, outweighs the fluid nuance. So we understand the mechanics of how the trial was run. Let's talk about the actual human beings enrolled in this trial.
Let's do it.
Who were these 498 analyzed patients? What did their baseline characteristics look like? We need to know if these patients look like the ones we see every day.
This was a genuinely sick, highly representative population. The median age was 66, which is standard for adult medical ICUs. When we look at severity of illness scoring, the median Apache 2 score was 21, and the median SOFA score was 7.
Let's translate those scores for the listener, because sometimes we just throw numbers around.
Good idea.
An Apache 2 score evaluates chronic health, age, and a multitude of acute physiological derangements. A score of 21 suggests an estimated mortality risk in the neighborhood of 40%.
Very high.
And a SOFA score, the sequential organ failure assessment, measures the dysfunction of 6 different organ systems. To get a SOFA score of 7, a patient likely has profound respiratory failure requiring a ventilator, cardiovascular failure requiring vasopressors, and perhaps acute renal or hepatic dysfunction. These are not patients who are just hanging out in the ICU for observation after a minor procedure. These are profoundly ill, multi-organ dysfunction patients. These are the patients taking up all of your mental bandwidth on a shift.
Without a doubt, they were critically ill. When we look at the underlying etiology of their shock, sepsis and septic shock were by far the most common causes of their metabolic acidosis, accounting for about half of all the patients enrolled.
Classic.
And crucially, looking at their renal function right out of the gate, nearly half, 46.2% to be exact, already met the KDIGO criteria for acute kidney injury at baseline before the trial drug was even hung.
That is a critical detail. We are not just trying to prevent kidney injury in healthy kidneys. In almost half the patients, the insult has already occurred. The creatinine is already climbing, the urine output is already dropping, and we are trying to mitigate kidney injury that is actively evolving.
Exactly. And to give you a picture of their biochemical state at enrollment, their median baseline TH was 7.26. Their median lactate was 2.5 millimoles per liter.
Okay, so acidemic, but not profoundly lactic.
Right. So they are acidemic. They have a modest lactate bump indicating tissue hypoperfusion, and they are on a median norepi dose of about 0.114 to 0.15 micrograms per kilogram per minute.
That is the absolute classic bread and butter ICU patient in shock. every single person listening to this right now has taken care of this exact patient within the last week.
Which is exactly what makes the results of this trial so broadly applicable and vital to your daily practice. So we know how sick they were. We know how rigorously the intervention was blinded to protect against bias. Now, what was the primary yardstick for success?
Right. What were they actually measuring?
What were the investigators actually measuring to see if the bicarb worked?
The primary outcome in SODa-BIC was a composite metric known as MAKE-30. MAKE-30. It stands for Major Adverse Kidney Event within 30 days.
And it is absolutely essential to break down its composite parts to understand why this is such a robust, rigorous endpoint in modern critical care nephrology trial.
Yeah, let's break it down.
MAKE-30 is defined by the occurrence of any one of three disastrous things: death from any cause, the use of renal replacement therapy, or persistent renal dysfunction.
And how did they define persistent renal dysfunction?
It was strictly defined as a final inpatient serum creatinine value closest to day 30 that was 200% or more of their baseline value.
I really want to pause here and dig into the methodology of this because I think a lot of clinicians look at composite outcomes with suspicion.
They absolutely do.
They think researchers just group a bunch of endpoints together to make it easier to find a positive result. Why do we use a composite like MAKE-30? Why not just look at who needed dialysis? Why do we have to lump death in with kidney dysfunction?
It is a great question, and it comes down to a vital statistical concept called competing risks. In the ICU, death is the ultimate competing risk. Let me give you a hypothetical scenario to illustrate this.
Okay, let's hear it.
Let's say we design a trial testing a new drug to prevent the need for dialysis. We enroll 2 patients. Patient A gets the placebo. Their kidneys fail, but they also have refractory shock, and they tragically die on day 3 of their ICU stay.
Okay.
Because they died so quickly, they never lived long enough to receive renal replacement therapy. Now, patient B gets the experimental drug. They survive the initial shock, they live for 2 weeks, but their kidneys never recover, and on day 10, they get placed on dialysis.
Okay, I see where this is going.
If your trial only measures the need for dialysis as the outcome, patient A who died is counted as a success because they technically never received dialysis.
Oh, wow, yeah.
Patient B who lived but needed dialysis is counted as a failure. The data would paradoxically suggest that the drug that let the patient live long enough to get dialysis is worse than the placebo that let the patient die on day 3.
That is a brilliant explanation. The competing risk of death completely invalidates dialysis alone as an endpoint. If you die, you can't get dialyzed. So MAKE-30 solves this by grouping the worst possible outcomes together. If you die, you hit the MAKE-30 endpoint. If you live but need a dialysis machine, you hit the endpoint. If you live, avoid dialysis, but your kidneys are permanently destroyed with a massive creatinine spike, you hit the endpoint.
You've got it.
MAKE-30 is the gold standard patient-centered endpoint because it is resilient to those competing risks. It captures the true holistic burden of the illness on the patient.
Exactly. So we have a pristine trial design and the gold standard outcome measure. Did the early protocolized administration of sodium bicarbonate move the needle for these patients?
Let's reveal the primary findings with absolute clarity. The incidence of a major adverse kidney event within 30 days, the MAKE-30 outcome occurred in 40.2% of the patients in the bicarbonate group.
Okay.
In the placebo group, it occurred in 39.4%.
That is an adjusted difference of 1.2 percentage points with a p-value of 0.78.
Okay, let me play devil's advocate here. You say an adjusted difference of 1.2 percentage points. Some might look at that and say, well, maybe if they enrolled 10,000 patients, that 1.2% difference would become statistically significant. Maybe there's a tiny signal of harm with bicarb.
That is where we have to look at the confidence intervals, not just the point estimate. The 95% confidence interval for that difference ranged from minus 6.9 percentage points to positive 9.4 percentage points.
It's all over the place.
It widely crosses 0. This is not a situation where the trial was underpowered to detect a meaningful difference. This is a completely, unequivocally non-significant difference. Statistically and clinically, the outcomes were identical.
Wow.
Treating the moderate metabolic acidosis with a 5-hour sodium bicarbonate infusion did absolutely nothing to change the primary outcome.
The intervention failed to prevent major adverse kidney events. It is a stunningly neutral result. And when we unpack the secondary outcomes, the picture remains incredibly consistent. It doesn't waver.
Nope, it stays flat.
There was no significant difference in in-hospital mortality by day 30. It was 25.4% in the bicarb group and 24.0% in the placebo group. Again, No difference.
And what about the use of renal replacement therapy within 30 days? This is the crucial point.
Hit us.
This was the supposed golden ticket from the older, unblinded bicarb ICU trials. This was the reason everyone was hanging bicarb to protect the kidneys and avoid the dialysis machine.
Right. So what happened to that benefit when the blinders were put on?
In the SODa-BIC trial, renal replacement therapy, or RRT, was used in 16.8% of the bicarbonate group and 20.9% of the placebo group.
Okay, slightly lower.
Yes, the adjusted difference was minus 3.9 percentage points, but, and this is key, the 95% confidence interval crossed zero, ranging from minus 10.6 to positive 2.7. The p-value was 0.24. It was not statistically significant.
I want you listening to really think about those numbers. Stop what you were doing and think about this. Think about those previous unblinded trials that showed significantly less RRT with bicarb. Once we blinded the clinicians in SODa-BIC, once we took away their knowledge of what fluid was hanging and forced them to look only at the patient's clinical trajectory, that supposed benefit essentially vanished. The difference shrank to statistical insignificance.
It is a profound revelation. It strongly implies that in the older trials, the decision to initiate RRT was heavily, unconsciously influenced by the clinician's anxiety over seeing an uncorrected low pH, rather than a true biological protective effect of the bicarbonate on the renal tubules themselves.
It is an incredible lesson in cognitive bias. It is a lesson in why double-blind randomized controlled trials are the absolute apex of evidence-based medicine. Blinding matters.
It matters tremendously.
Especially when human judgment, like deciding when to call nephrology for a VAS cath, is a component of the measured outcome. We are humans, we get scared when numbers look bad, and we react. The blind prevents that reaction from tainting the science.
So the clinical outcomes didn't change. Death didn't change. RRT didn't change. But this brings up a huge fundamental question for the bedside clinician.
Let's hear it.
A skeptic might look at this and say, well, maybe the outcomes didn't improve because the bicarb didn't even work. Maybe 500 milliliters of bicarb wasn't enough to fix the acid-base derangement in a patient in profound shock.
Because if the bicarb didn't actually fix the pH, then of course outcomes wouldn't improve.
Right. We have to look at the physiological efficacy versus the clinical reality.
That is a crucial question. Did the drug do what it was supposed to do chemically? And the data from the trial is very clear on this. The intervention did precisely what it was supposed to do chemically in the bloodstream. We have excellent treatment separation in the laboratory values between the two groups.
Yes, the separation was stark. If you look at the arterial blood gases during the first 24 hours after randomization, the highest median pH achieved in the bicarbonate group was 7.43, compared to a much lower 7.37 in the placebo group.
So it worked.
It absolutely worked. The highest median serum bicarbonate level was 26 millimoles per liter in the treatment group, a perfectly normal level, versus 21 in the placebo group.
And it wasn't just a transient 1-hour spike that immediately faded either. The durability of the chemical correction was impressive. The recurrence of metabolic acidosis over the first 7 days was drastically reduced in the treatment group.
Huge difference there.
Only 32% of the patients who received bicarb had a recurrence of their acidosis, compared to an enormous 55.7% in the placebo group. So chemically, physiologically, in the extracellular space in the blood plasma, the bicarbonate was highly effective at neutralizing the acidemia.
It fixed the numbers beautifully. It did exactly what it said on the label, but it did not fix the patient.
This is the ultimate textbook example of treating the monitor instead of treating the patient. Let me give you an analogy to conceptualize this disconnect.
I love analogies.
Imagine you have a car and the engine is failing catastrophically. The oil is leaking out of the block, the timing belt is shredded, the cylinders are misfiring, and on top of all of that, there is a massive, ugly patch of rust on the hood.
Okay, I can picture it.
Giving sodium bicarbonate in this scenario is exactly like meticulously sanding down the hood, applying primer, and painting a beautiful new clear coat over the rust spot.
I like where this is going.
The exterior, the pH number on your monitor, the hood of the car looks fantastic. You step back, wipe your hands, say, wow, that looks much better. But you haven't touched the engine.
Not at all.
The underlying cellular shock, the profound mitochondrial dysfunction, the severe lack of organ perfusion. The engine hasn't improved at all. The car is still going to break down, no matter how shiny the hood is.
That is a phenomenal analogy. The acidemia is often the rust. It is a manifestation of the underlying shock state, a byproduct of anaerobic metabolism and renal clearance failure. It is not necessarily the primary engine of cellular destruction in this moderate pH range.
Right.
And we see this massive disconnect between the improved numbers on the lab printout and the actual patient trajectory when we look at the process of care measures in the trial.
Right, because if we go back to our earlier physiology discussion, we said that fixing the pH was supposed to make the vasopressors work better.
The alpha-1 receptors.
Exactly. It was supposed to change the shape of the alpha-1 receptors back to normal, reverse the catecholamine resistance, and allow us to wean the norepi. If that theory holds true, we should see patients in the bicarb group coming off norepi sooner. Did we see that?
We absolutely did not. Despite the significantly better chemically corrected pH in the bicarb group, there was absolutely zero difference in the median number of vasopressor-free days. None.
None at all.
The highest and lowest median norepinephrine infusion rates were virtually identical between the groups over the first 24 hours. They required the exact same amount of chemical blood pressure support.
That's crazy to think about.
Furthermore, there was zero difference in RRT-free days, or ICU-free days. The patients stayed just as sick, required just as much organ support, and lingered in the ICU just as long, regardless of whether their blood gas looked pretty or ugly.
Okay, let's unpack this. Why? Why does fixing the extracellular pH fail so spectacularly to translate into cellular and clinical improvement?
I think we have to go back to basic chemistry.
Let's do it.
We have to talk about the Henderson-Hasselbalch equation and what actually happens on a molecular level when you infuse sodium bicarbonate into a human vein.
Yes, this is the crux of the physiological failure of exogenous buffers.
Okay, set the scene for us.
When you administer sodium bicarbonate, NaHCO3, it enters the bloodstream and immediately seeks out the excess hydrogen ions. The bicarbonate molecule binds with a proton to buffer the acid. This reaction yields carbonic acid, H2CO3.
Right, basic acid-base chemistry.
But carbonic acid is highly unstable in the blood. It rapidly, almost instantaneously, dissociates into water, H2O, and carbon dioxide, CO2.
Carbon dioxide, that is the key to this entire mystery. You're actively generating massive amounts of CO2 in the venous blood.
And we have to look at the physical properties of these molecules. Bicarbonate is an ion. It is charged. Because it is charged, it stays primarily in the extracellular space, the bloodstream. It has a very hard time crossing the lipid bilayer of the cell membrane.
Right.
But CO2 is a dissolved gas. It is highly lipid soluble. It diffuses rapidly, freely, and instantly across all cell membranes.
Exactly. So think about what you are doing dynamically. You infuse bicarb, it neutralizes the acid in the blood, creating CO2. The blood plasma becomes more alkaline, so your arterial blood gas looks great.
The hood of the car looks shiny.
Yes, but that newly generated CO2 immediately diffuses straight into the cells. Once inside the cell, it encounters intracellular water. The reaction runs in reverse.
Oh, no.
The CO2 combines with water to form carbonic acid, which dissociates into bicarbonate and a hydrogen ion.
You are creating a paradoxical intracellular acidosis. Let's build another analogy here.
Go for it.
Imagine a building. The hallway of the bloodstream and the locked offices are the cells. The hallway is covered in dirt. That's the acidemia. Giving bicarb is like bringing in a giant broom. You sweep all the dirt out of the hallway.
Okay.
The hallway looks spotless. Your blood gas looks great. But where did the dirt go? You swept it all right under the locked doors of the offices.
Oh, wow. And the people inside the offices, the cellular machinery, are now choking on the dirt.
Exactly. You paint over the rust on the outside, but you might actually be accelerating the engine failure on the inside. The myocardial cells, the vascular smooth muscle cells containing those alpha-1 receptors we talked about, they might be experiencing an even more hostile, highly acidic environment internally.
That makes total sense.
The intracellular pH drops even as the extracellular pH normalizes, which perfectly explains why the vasopressor requirements didn't budge one bit. The alpha-1 receptors might be facing an even worse acidic environment from the inside.
It is a humbly sobering reminder that our well-intentioned interventions often have complex, compartmentalized effects that we simply cannot fully appreciate just by looking at a venous or arterial blood draw. The blood is just the transport highway. It doesn't tell you what is happening inside the factories.
This is true.
Now, whenever a major trial like SODa-BIC shows a negative overall outcome, it is human nature. It is intrinsic physician nature to resist the finding. We dig through the data looking for a silver lining. We immediately ask, well, maybe it didn't work for everybody, but what about the really sick ones? What about the patients whose kidneys were already failing? Surely it worked for them.
It is a necessary and standard part of analyzing any major trial. You have to look at the subgroups. Did the investigators hunt for a signal of benefit in specific patient populations?
They did. They rigorously broke down the data into 8 pre-specified subgroups to hunt for any signal of benefit. They created a forest plot, a graphical display of the results across different populations.
And how did they divide them up?
They looked at patients stratified by their pre-randomization pH level, dividing them into those with a more severe pH below 7.25 versus those 7.25 or higher. They looked at the stage of acute kidney injury at enrollment, comparing those with no AKI or stage 1 versus those with advanced stage 2 or 3 AKI.
Okay, the sickest kidneys.
Right. They looked at the type of acidosis, separating out high anion gap acidosis, typically driven by lactate or unmeasured anions, versus non-anion gap hyperchloremic acidosis.
So they sliced and diced the data every way imaginable. And what did the forest plot actually show?
It showed a completely unyieldingly straight vertical line right down the middle of the graph, the line of no effect. Not a single pre-specified subgroup showed a statistically significant benefit from the early administration of sodium bicarbonate.
Let's explicitly answer the questions for the clinician looking for an excuse to use it. Did patients with the more severe acidemia, the ones with a pH less than 7.25, benefit from bicarb?
Yeah.
Did the patients with advanced acute kidney injury, the ones with stage 2 or 3 AKI, the exact population that the old bicarb ICU trial suggested, might benefit the most? Did they see any reduction in MAKE30 or the need for RRT?
Absolutely not. The benefit completely evaporated when blinded.
What about the type of acidosis? We always say bicarb is better for non-anion gap acidosis. Did patients with a high anion gap versus a non-anion gap see a difference in outcomes?
No difference whatsoever.
Medical versus surgical admission.
No difference.
I really, truly want to emphasize this for you listening. As critical care providers, we love our nuances. We love to find the exception to the rule. But there's very, very little room left in this data to justify the routine use of bicarb in this broad population of vasopressor-dependent shock patients with moderate metabolic acidosis.
The data just isn't there.
You can no longer just say, well, their AKI is stage 2 and their pH is 7.21. I remember an old paper, I'm going to give it to protect the kidneys. The highest quality blinded data we have simply does not support it. It is an illusion. But we have to look at the other side of the coin. If it doesn't help the patient, does it actively hurt them? Let's discuss the safety profile of the intervention. Is it a benign waste of time, or is it toxic?
The trial found that the infusion of sodium bicarbonate was generally very safe. The overt adverse event rate was remarkably low. Only 1.6% of patients in the treatment group experienced a recorded adverse event, compared to 0% in the placebo group.
That's pretty low.
Yes, and that 1.6% was driven almost entirely by one specific issue: hypokalemia requiring pharmacological correction.
Which, if we think about it, is entirely predictable physiologically. It's a basic consequence of acid-base manipulation.
Let's explain why the potassium drops.
Sure. Every cell in the body has hydrogen-potassium exchange pumps on the membrane. As you give bicarb and the extracellular blood becomes more alkaline, the body tries to compensate. Hydrogen ions move out of the cells and into the blood to try and bucker the new alkalinity. But to maintain electrochemical neutrality across the cell membrane, you can't just move positive charges without balancing them. Potassium ions move into the cells. So the potassium leaves the bloodstream and the serum potassium level on your lab draw plummets. It's a known, understandable, and manageable side effect.
It is manageable. You just give IV potassium, but it raises a much larger, more philosophical point about how we evaluate safety and utility in the intensive care unit.
Exactly. I feel very strongly about this. Just because a drug doesn't overtly kill a patient by stopping their heart doesn't mean it's benign. In the ICU, safe is a relative term.
Tell me about it.
Think about the hidden costs of an intervention that doesn't work. Giving a bicarb infusion requires precious nursing time to physically mix the medication, program the pump, and hang the bag. It occupies a dedicated, highly valuable lumen on your central line, a lumen that might be needed for a second vasopressor or antibiotics or sedation.
That line access is real estate.
Exactly. And it adds half a liter of sodium-rich hyperosmolar volume to a patient in shock who is almost certainly already third-spacing fluid and becoming fluid overloaded. And on top of all that, it requires the doctor to write the order, monitor the potassium, and react to the changing labs.
It is a massive allocation of human and technological resources for an intervention that yields no benefit.
Right. If an intervention provides absolutely zero clinical outcome benefit, but consumes time, line access, and cognitive bandwidth from a stretched care team,
Yeah.
well, that is not a neutral intervention. That is a net negative at the bedside.
I agree completely.
It actively distracts from the core, life-saving therapies that actually matter, like sourcing the infection, optimizing the ventilator, or managing the hemodynamics.
That is a highly practical, holistic view of patient care. It is an argument we need to hear more often. It's not just about the biochemical safety profile. It's about the real-world resource allocation and the cognitive load placed on the care team.
So we have waded through an immense amount of physiology, trial design, and statistics. We need to synthesize all of this heavy data analysis into actionable, concrete bedside advice for your next ICU shift.
The bottom line.
When you walk into the unit tomorrow, what is the core practical takeaway from the SODa-BIC trial?
The fundamental conclusion is definitive and clear. Do not use sodium bicarbonate routinely for moderate metabolic acidosis in critically ill patients receiving vasopressors with the expectation of improving patient-centered outcomes.
Say it louder for the people in the back.
Right. Giving it does not reduce major adverse kidney events, it does not reduce mortality, it does not get them off vasopressors faster, and it does not meaningfully reduce the need for renal replacement therapy.
But this is a crucial but. We have to respect the boundaries of the trial. We are not saying to rip the bicarb off the crash cart, throw it in the garbage, and banish it from the hospital.
Oh, definitely not.
There are specific caveats based on the trial's exclusion criteria.
Absolutely. The trial intentionally excluded patients where the investigators felt withholding bicarbonate would be medically unethical or immediately unsafe. Bicarbonate still has a definitive life-saving role in highly specific select clinical scenarios that fall outside the bounds of moderate shock-induced acidosis.
Give us some examples.
For example, profound, imminently life-threatening acidemia, say, a pH of 6.9 or 7.0, where the enzymes and proteins are denaturing and the physiology is completely unraveling. It remains an absolute cornerstone for the emergency treatment of severe hyperkalemia, where shifting potassium into the cell buys you time to dialyze.
Right.
It is vital in specific toxin-related ingestions, like tricyclic antidepressant overdoses, where the sodium load overcomes the sodium channel blockade in the heart, or salicylate toxicity, where alkalinizing the urine traps the aspirin and forces its excretion.
Classic tox indications.
And it is entirely necessary when a patient has proven massive bicarbonate losses, such as a high-output pancreatic fistula or profound severe diarrhea.
Right. Those last examples are normal anion gap metabolic acidosis, where the body has literally physically lost its buffer out of a drain or the GI tract. You have to replace what is lost. But for the vast majority of your patients, the classic septic shock patient with a high lactate, an evolving acute kidney injury, and a pH of 7.22, the final verdict from the highest quality evidence is clear. In this population, bicarbonate improves your numbers, not your patient's outcomes.
It paints the rust, but it doesn't fix the engine.
Which leaves us with a fascinating, almost provocative thought to end on. A thought that should keep us all questioning our assumptions. We have operated for decades, generations of doctors, on this physiological premise that correcting the pH in the blood will improve vascular tone and reduce catecholamine resistance.
It is taught as gospel in every critical care fellowship in the world.
But the SODa-BIC trial showed absolutely zero difference in vasopressor-free days or norepi requirements, despite perfectly correcting the pH in the blood. So it forces us to ask a really uncomfortable question about our own medical dogma.
It really does.
Are our long-held assumptions about the direct relationship between acidemia and catecholamine resistance completely wrong? Or, as we speculated earlier with the hallway and the office analogy, is the intracellular space, where the actual work of the cell is done simply untouched, or even actively worsened by the extracellular buffer we are so proudly hanging on the IV pole?
It's a huge question.
If the true engine of shock is running inside the cells, deep within the mitochondria and the cytoplasm, perhaps no amount of exterior paint will ever make a difference.
That is the beautiful, immensely frustrating reality of critical care medicine. The deeper we dive into the data, the more rigorous our trials become, the more we realize how much of the underlying cellular physiology we still have yet to truly understand.
And that's exactly why we keep reading the literature, keep questioning our own deeply held assumptions, and keep coming back to the bedside. Thank you for joining us for this deep dive. We will see you next time.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.
Read it in the NEJM, a trial big and grand for metabolic acidosis across the land. 500 patients got the bicarb or placebo, hoping for a kidney fix, a scientific hero. But the 30-day major adverse kidney events showed no lower risk from bicarb for all intents. No lower risk from bicarb for all